to the faculty practice. So now they can hear us over there through the
at about that same time, the treatment of high blood pressure, hypertension with drugs was in its inception. There were a few drugs available. There are very few people actually treated. And since then, as you know, this is a radically changed and advanced area of preventive cardiology. And it is preventive medicine, and it suffers all of the growing pains, you might say, that come with success in knowing that it works. Lowering blood pressure prevents cardiovascular disease and renal disease as well. It begins with outpatient assessment, proceeds through prescription writing and follow-up and maintenance of care over long periods of time. Now 50 years, we have patients who've been treated for 30, 40, 50 years who are alive and well and functioning. But that applies to a small fraction of the population, and how to go from, you might say, the small experiment of treating a few thousand people and in a trial to the delivery to the nation, and not only the nation, but the globe. Because in every advanced country, hypertension is more and more of a problem, and cardiovascular disease, which is preventable, is more and more a target. So with that as background, what I want to do today is how do I advance?
Okay.
Just click on the mouse.
You can use the keyboard or the mouse or this easier.
Okay, so having mastered modern technology to a certain extent, I want to show you the big picture, the most recent experiment to validate the big picture, go to the implementation or advice as a result of the current status, advice from those on high who write advice. I have to tell you that I am not on the take. However, it's interesting that this, you know that we sign these forms, conflict of interest forms and disclosure forms. And what's not, the concern from your dean's office is the drug companies, affecting our judgment. But you should understand that, as I'm going to talk about guidelines, who writes the guidelines? Those appointed by the American Heart Association or the American College of Cardiology. Are these unbiased and fair-minded nonprofits? And the answer is no. They are fair-minded but not unbiased. You'll see, believe certain things about how medicine should be practiced and delivered for the benefit of the nation. So we're all affected by this. If your best friend is a cardiovascular epidemiologist, you will be exposed to views about prevention that might be different from a more skeptical person. But that's the only disclosure I think you need to know. So our first patient today is familiar to you. You may have come in referred by a screening site, or may actually have just walked in for some reason and is referred to you. And this is our patient. African American background. He's 45 years old, early middle age maybe. He has started some treatment, and he's a little overweight. There's no history for him of another risk factor for us to be concerned with at present, and these are the numbers you can see. And that next to last line says that if you use one of the risk calculators that I'll come to later, his 10-year risk for cardiovascular disease is 5%, which you miss is, depending upon your point of view, is large or small. And there's a family history, not surprising. Okay, you all read clinical trial literature, I'm sure, daily, and you should, at least weekly. And which trial applies to this patient? Okay, everybody for number 1. Thank you. Number 2, forward. Thank you. Number 3, Hope 3. Number 4, Barbershop. Have you heard of Barbershop? If you have not, it's in the Times already and all the media, and I'll come back to it towards the end. But these are 4 trials that are relevant to this patient and varyingly relevant to the patients you see on a daily basis. Okay, so why the trials apply or not apply? Well, SPRINT, which you should know is the high goal, low goal treatment of hypertension, published last year, widely accepted as a new set of goals for treatment of hypertension. He's too young. And that's surprising, you might say, but that's my point, is that there are trials that don't apply. They don't apply entirely. Cord is a diabetes trial. He definitely doesn't relevant to him. HOPE-3 is a huge population-based study that includes large populations at high risk for cardiovascular disease, stratified in various ways. I think it's nice to be familiar with it. It doesn't really apply to U.S. urban population. And Barbershop will come to. It's not about songs, it's about treatment. Okay. None of you are familiar with Barbershop Harmony? Anybody? All right. Okay, SPRINT trial. SPRINT trial was published now, I guess 2 years ago, and it's provided the basis for our thinking about and treating hypertension in the U.S. It provides, as do some other trials, the rationale for the new guidelines for treatment of hypertension provided to us by the American Heart Association and the American College of Cardiology and recognized by many or nearly all organized medical organizations. Now, this is the background basic slide. This should have been seen by you in medical school or even high school, it's old. But this is the basic rationale for our view of treating hypertension as we do today. It's a composite meta-analysis published in 2002, reproduced in many texts and articles about hypertension. But the point is, for every age group that you can, the risk of cardiovascular disease, fatal cardiovascular disease, rises progressively from a systolic blood pressure, at 120, progressively upwards. Up and up. This is epidemiology. This is not trial data, but it is the root of all almost all recent clinical trial data. It tells you that lower the pressure, you lower the risk. Lower the pressure more, you lower the risk more. Down to 120. This is epidemiology. This is not trial data, but every epidemiologist should be and is usually familiar with this, and this is the way to link it. Links to trial design and links to policy, etc. Okay. Now, along comes SPRINT, published in 15, and it's a long gap between 2002 and 2015. But basically, when you run a laboratory, you do experiments. The experiment works, fits your hypothesis, or it doesn't. You do another experiment until you're convinced that the data appropriately taken fits your hypothesis. SPRINT is that experiment. It's the first. It's a unique trial because the designer said, let's go as low as we can and see if we can get better outcomes. This is this. I do advise that you reread it and the many articles that are issued from SPRINT as we go forward. Okay, age greater than 50, but they included, very importantly, a group above age 75 at the start, planned to do so. Community dwellers, functional in part, some frail by geriatric criteria, but living at home and active for the most part. Not diabetic. Diabetics were excluded from SPRINT, and those patients who already had a stroke were excluded. Those with coronary disease, and even post-MI, were included. So it's a population that I think we all see on a regular basis. Most were already treated. In order to conduct it at all, a large fraction, 40–50% of the nation whose hypertension is now treated, means that you can't find untreated patients. And so many of these were, in fact nearly all, were at some degree of treatment on entry. They were at moderately high risk, moderate, I'd have to say, but not very high, because the exclusions, and it was balanced in the design for groups that concern us to a great extent: gender, African American status. Other minority status is not balanced. So, for example, if you I think this applies to Native Americans, it's a bit of a stretch. I don't think it's terrible, but the point is, it's very hard to achieve adequate numbers in this kind of a trial going forward. But, so we're a bit slightly limited, but not very much. It certainly applies widely. The design, basically two groups, all hypertensive with and without treatment. One group gets treated to the standard goal of less than 140 millimeters mercury systolic pressure that has been in place for 15 years. And the intensive goal was to try to lower systolic pressure below 120 millimeters of mercury. And this has not been done very often, and I don't know the details, but my guess is that there are feasibility studies that suggest that you can do this. But most of us were not trying too hard to do it, say, 5 years ago, 10 years ago. Blood pressure, how do you take a blood pressure? As fast as possible. Wrong. They were appropriate, in my view, of taking blood pressure using a device, not ears and stethoscopes. And the Omron device that's available on the corner down here at CVS. And setting the patient in a quiet room and distracted, and hopefully they're undisturbed except by their own concern about their blood pressure. And 3 measures were taken, and those were used as the blood pressures at baseline and throughout the conduct of the study. Now, this is not what, and this was a criticism, it's not what we usually do. You're busy, patient comes in, someone takes the blood pressure, it's written in the chart, off you go. But the concern is the false positives. If you do it take blood pressure that way, you're going to get a lot of people whose pressures are higher, because if you simply took them a minute later, 2 or 3 minutes later, it would come down, and this is a white coat effect, if you will. And the hope was to avoid including too many of those, and that, in my view, that was entirely appropriate, and in fact should affect our practice. I think that if one learns anything from this kind of a study, is that we need to spend a little more time doing the test, taking the blood pressure. Now, quiet room, is that how quiet? You know, my mind's fairly quiet, but you know, if a truck goes by outside the window, or if there's chatter in the hallway and doors are closed, etc., etc. Now, it turns out there is a study that I won't show you the data, done in Europe, in which investigators asked the question, do you need a quiet room with nobody intruding? And the answer is no, it really doesn't make too much difference. Take the pressures, but take enough of them with an accurate device. So that's something I think is appropriate. Primary outcome, and you can see, and then it was planned for a 5-year trial, but was stopped prematurely, early, because of the trend of the results. Now, these are the blood pressures in the sprint for the standard treatment and the intensive treatment. And this is remarkable. I would not have anticipated this way, that this degree of difference between the two groups. The intervention group indeed took more drugs, about 1 drug class per patient over the time. So more drug treatment, but the results were astounding. And they fit with that earlier slide, the epidemiology slide. I say that was, you may say that was a predictive hypothesis, that if you lower blood pressure to this degree, you prevent disease. And it worked. These are the outcomes. Up top is the primary outcome, cardiovascular death, MI and stroke primarily. And on the bottom, for death from any cause. This was not anticipated. It was not. It was planned as a secondary endpoint. But again, if you said after 3.5 years you're going to reduce mortality this way, I think even the designers were surprised. But this is the outcome. Now, what about the particulars? Okay, this is subdivided by outcomes, and The blue is the intensive group. For the primary outcome, a significant, I don't know if you can see the asterisk at the bottom, but highly significant for death, highly significant. For cardiovascular death, smaller numbers, but highly significant. Heart failure, significant difference. Stroke rates were low and not significantly different. And this is a surprise, because in all older studies, in the earliest studies, stroke was the event to prevent. But that was then, when stroke rates were much higher for a lot of different reasons, when the treatment groups had higher pressures. So this isn't a terribly surprising finding. And with a longer duration of treatment, I think, and my belief is that there would have been a significant difference in stroke as well. Acute myocardial infarction, not at all different in groups, and this is perhaps a surprise, although the relationship of ischemic heart disease and blood pressure treatment over the many years in trials has always been a little bit fuzzy. So this isn't really a shocker. For the older group, that you and I, I'm sure, are seeing much more on a regular basis, the planned analysis was performed, and this shows the outcome. For the primary outcome, a highly significant and impressive reduction. For death, a significant smaller reduction for total death. For cardiovascular death, a significant difference. For heart failure, this is a worry. We can't prevent heart failure more, but again, the duration of the trial may account for that. Stroke, again, no real difference. And again, this older group, a little bit of a surprise. And for MI, a trend, but not statistically significant. Yes?
The y-axis just percentages. The y-axis.
It's absolute. It's percent.
Okay.
Yeah.
What is your impression of how the older patients in this trial reflect the typical older patient seen in primary care? In other words, do they help you?
Well, you know, I think you're in actually a better position to answer the question than I am. I see patients. I see a lot of older patients, to be sure, and there are a lot of referred, but mine is largely a referred practice, so I see the problems.
Yeah, I guess what I'm getting at is, in terms of the typical patient in the study, you mentioned there were some that were frail. I mean, how many were frail? How many had multimorbidity? That's kind of patients that a lot of times we see.
Okay, those defined as frail, no, they're outpatients and functioning, so using scales for that, how many falls, etc. As I remember, in the older group, it was something like 30%. That's a guess. So, and no nursing home patients. So this is a functioning population. Okay. These are, and by the way, since 15, which is now 3 years ago, the papers keep coming out on this every couple of weeks about analysis of subgroups or trends in other areas, as you'll see. Okay, this is one that I think is important. New left ventricular enlargement. We know that's a risk factor, and it was prevented. You see, this is the left-hand side of the hazard ratio. That nearly all of the groups, for nearly all the groups, the intensive care strategy reduced the occurrence of new left ventricular enlargement by EKG, not echo. And you might say, well, EKG is, we get a lot of false positives, and that's true. So wouldn't it be nice to have echo data? And in a study of this size, it's not yet been published or wasn't done. I suspect that they had some subgroups with echo, but I can't show you that data. But this is, again, it's impressive that this happens. Now, the other side of the coin is, what if we have left ventricular enlargement by EKG at the start? Does it get better if you lower the blood pressure more? And the trend is shown here in this part of this trial. And this is on the right, the degree of regression of left ventricular enlargement by EKG. Again, not echo. But this is the kind of thing that fits. Those of you who are familiar with the Cornell New York Hospital's research programs, they've spent a lot of effort on the relationship between left ventricular enlargement and blood pressure and outcomes. Then this is good. This is good news. Okay. So the impact of this SPRINT for those of us in this area, in this field, is impressive. It's consistent with those epidemiologic surveys. You like to see that in clinical trials, that your hypothesis is borne out. It's not proof of concept, it's evidence for a concept, solid evidence. And SPRINT was the first trial to really be this aggressive in its design to see, can you do this? So that of those involved, I was involved early on in one of the planning study sections, and there were many. This was a study that was designed after a lot of thought and effort on the part of the NIH and a lot of people. So I think of it as a success story, as a trial. Okay, is it the last word? Well, some of the criticisms, I won't go into a long list of why some people don't believe it or find it limiting. The blood pressure measurement issue. So, and I think the message here is a few more blood pressures can be very helpful. Never rely on the first blood pressure of the patient because it's 2 to 3 times it'll be higher. And we want more blood pressures. A lot of them were treated at the onset, so that limits interpretation. And most of them were relatively low risk for future cardiovascular disease. But the outcomes tell you the risk was high enough. And it's consistent with other trials that didn't show a benefit, other trials or observations that didn't show a benefit of lowering the pressure all the way down. However, one of these is ACCORD, is a diabetes trial. ACCORD had a very similar design, standard care versus intensive care for lowering the blood pressure, and it was a negative, a disappointment. It didn't work. But it was a diabetes trial, and those with diabetes are different. Their outcomes are different. Their event rates in different categories are different. So that's not terribly surprising. Then along comes another meta-analysis, which there's got to be one, right? Looking at all trials that you could find in which you can find lower pressure groups and higher pressure groups. And that's this one, published recently, this year, by Dr. Brunstrom, and pulling together all these different trials. And if you look at the bottom line diamond, it's small, but it's there somewhere. Okay. No significant effect in this meta-analysis. Now, the SPRINT is here, and all the others are here, and this is the net result. No significant. So, why? Different populations, and it's a meta-analysis, so some of the trials are small, some are big. This is what's out there, and if you think about it, but my view is that SPRINT is a very compelling trial and hard to avoid. This conclusion was published shortly after SPRINT, based on calculations for the nation. So we now go from a clinical trial with carefully vetted participants at the start, very carefully conducted, and now projecting to the U.S. population. So you can see it. The present analysis projects that if intensive blood pressure treatment, as in SPRINT, were widely adopted at the nation, this is the U.S. population, not Canada, not other parts of the world. A large number, 108,000 deaths would be prevented annually. Now, to me, that's a significant number, and I'd like to be a part of those who are doing it. But, and I didn't go into detail, the side effects are real. But in general, the side effects are, one, not fatal, and not hospitalization causing, so that a little dizziness is an adverse effect. Real and bothersome, and we don't want it, but nonetheless, that's what they're including in the side effect calculation. Little increase in creatinine. We've reached, I think, a ratio of 1.5 to times the baseline, it's considered an adverse effect. We don't want it, but how bad is it in relative to the benefit? So there will be anticipated side effects. They will be mild, not acceptable, but mild. And so the net prediction is that going to the sprint strategy ought to be remarkably effective. However, and of course, this will come up, one thing I think you all know on a daily basis is, can you achieve the blood pressure effects of sprint in an open population? Can you, in fact, lower pressure that much? Will patients refill prescriptions? Will they take their medication? So the adherence issue always pops up, and you face it and I face it. So that is a limiting, you might say, a limiting aspect of the strategy. Now, however, once Sprint became available to its designers, the designers became the guideline writers. So Paul Welton, whose name is first author on many of these same papers, is first author for these new recent guidelines for treatment of management of hypertension that you have to be familiar with. And so one is linked to the other through, one, the hypothesis generated by the epidemiology to the experiment, and two is the author. Author of Sprint and author of the guidelines. So is that bias, or is that appropriate belief in what you do? And Dr. Welton, he spoke in New York not long ago for the New York Heart Association, I believe. But anyway, he's a highly respected epidemiologist, and so I don't think of him as a biased individual, but he has a belief, and we have to be at least recognize it. Results of Sprint were the result of the guideline, new guidelines. The guideline writers got to work very quickly, and it turned out these new guidelines presented the American Heart Association 2 years ago, almost a year and a half ago, published in several journals, including our own Journal of the American College of Cardiology, whose editor is Val Fuster. So we think of this as that we're active participants in the dissemination of this information. It's long, nearly 300 pages, at least 400 references. I'm sure you want to read it at bedtime, because it will put you to sleep. But it's important, and the most important aspects I'll tell you about from my point of view. But nonetheless, this is new. It's based upon the most recent evidence. It is truly evidence-based, as the best evidence that can be assembled. And it's an attempt to boil down all of this epidemiology and trial data into practical application. Okay, new recommendations as a result of this. You might anticipate lower blood pressure goals. Lower blood pressures for classifying hypertension 130 over 80, and for this, the goal of treatment 130 over 80. So that's new. An increased emphasis on getting the patient's blood pressure outside the office, at home. At home will become, I think, the new standard for care. And there are a lot of publications to show this, why this ought to work. So the new classification, if you're using home blood pressures, what if they're lower? What if they're really normal? What do you call that? We call it white coat hypertension. What if they're higher? And this is a tricky problem, because higher from what? If you screen a patient whose blood pressure is normal, you go next case, go on. So how do you find those whose blood pressure is higher out of the office, those with masked hypertension? And the strategy for this isn't clear as to how many patients we should have take home blood pressures who are not hypertensive in the office. There are some clues. Higher normal. So 129 is more suspicious than 119 as an outpatient pressure. Presence of something like left ventricular enlargement on EKG with an apparent normal pressure in the office. Could be masked hypertension. We need outside of office pressures, home pressures, it's what we're using more and more now. Then, at those with borderline pressures, high normal, slightly elevated, should we treat them or not? Well, that's where the risk calculation comes in as a basis for deciding on treatment and how aggressive to be. And then number 4, I'm going to come back to this because this lifestyle, the guideline writers have a lot of faith that lifestyle improvement will solve the problem of mild, slightly elevated blood pressure. Systolic 133, and they lose 20 pounds, and now it's 125. Will that happen? That's a big issue. It can happen, but will it happen? So we'll come back to that point. Okay, this is the grid for classification, and you can see it really takes the thresholds down a lot to now classify someone as stage 2 hypertension because their blood pressure is 141 systolic on treatment, for example. So this is the grid, and we all have to be aware of it, but it is a little bit oversimplified because they draw lines here, and what we want are a little more recognition within those lines. Within stage 1, there's systolic at 131 and 139. And within stage 2, there's 141 and 159. I don't think these are helpful. But that's perhaps after a few years, we'll see how many doctors are using these and find them helpful or how many are not. Okay, this just shows, it's a slide that Franz Messerli published a year or 2 ago, just simply to show if you change the threshold for diagnosis, that there'll have to be more people who have it because the population trend, the population average is still well below the threshold for hypertension. So this is shows the increased fraction of the population we're dealing with. And this was published last year also. And on the left-hand side, the prevalence of hypertension, that's defined as either 140 or 130, has got to go up if you lower the threshold. The middle bars show the percentage of those who are hypertensive, who would be on drug treatment if the guidelines were followed, that's the blue bars, or according to the calculations of the previous guideline, the JNC 7, 15 years ago. And the reason, see, this doesn't make sense. And I'm not sure it does make sense, but it reflects the faith of the guideline writers that non-drug strategies will be effective. So the lifestyle improvement. That's really what this means. It's a hope. Now, the right-hand set of bars are those who are predicted to be above the blood pressure goal, 130 over 80, for the 2 guidelines, the old one and the new one. And you can see a much larger fraction would be above the goal. But these are the ones you hope to manage with lifestyle improvement, in large one hopes. Okay, now, what about those slightly elevated blood pressures, but high risk or low risk? And this is where the American College of Cardiology and the calculations, risk calculations, help us. How many of you have these on your iPhone? Good news. Good news for me. I could pretty much done with the talk. Because this is, I think, a very helpful tool, and patients can see their blood pressures, but there are limits. Okay, what's not included in the guidelines? And this is the top blue items are in the guideline, in the calculator, excuse me, and what's left out and relevant to us as practicing doctors. I think that not to include a thought about family history, and particularly in counseling patients, but as a risk factor itself, is not a good idea. And I think it should be included. Now, it's hard to formally include it because it means so many different things, but I think you know what I mean, and you probably are already taking that into account in your recommendations to patients. The EKG, left ventricular enlargement, we do it on everybody. So why should it not be included as a risk factor in the calculation? It's not. Don't know why. We all have, there's no dearth of EKGs to help us with this, but it's not. out-of-office blood pressures, how to clock them into risk in the formula. And the answer is, well, there isn't one. There may well be, because there's enough data on home blood pressures to include it as a part of the risk calculation, but it's not at present in it. Okay, so this is, I think, familiar. It's helpful to have this information to counsel patients, to think about the urgency of lowering their blood pressure. But bear in mind that many, many, many patients will not fit into high-risk categories because there's no trial evidence to show that they benefit, and particularly those less than 50 years of age. It just, the trials weren't done. The few that were done years ago. The event rates were too small because of the younger age of the population to give us the kind of hard trial evidence you get in sprint. Okay, but this is the way of looking at who will be at this 10% or higher risk calculation if you look at other risk factors. And you can see if you're only hypertensive, that's the left-hand bars, and this is comparing men and women, your risk numbers are low. Now, 6% too low to start treatment. That's your decision, not mine to advise. You know the patient. But once you add risk factors, then the urgency of treatment goes up and up in men more than women, but women are at risk, and risk can be reduced, as in sprint, because there's no real gender difference in sprint between men and women. So this is a bit misleading that women are somehow immune. So no. And this again shows by age groups, if you're a man and you're 60 years or older, you're hypertensive. Lower the pressure. So that's the implication. And if you're a woman, you can wait a little bit longer, assuming you don't have other risk factors to be considered. So this is helpful, but the decision making should be yours and not the calculator. This is the big picture, and I'm not going to go through it, but make a couple of points. If you look at across the board, everybody gets lifestyle improvement. It doesn't matter. Well, I think that's what you all practice. That if you have someone who's overweight and their blood pressure not elevated, you still want to reduce the risk. If it's elevated, and let's say that we're in the middle here, stage 1 hypertension, you go down the road. And you'll see that the first step, and maybe the only step, is lifestyle improvement. And if it works, then you don't have to use drug treatment, and you'll follow the patients. Now, the timeline here, I'm curious, because all the guideline writers want this all done very quickly. So they want reassessment in 3 to 6 months. I don't know how practical that really is. A lot of the patients I see are working, you get them in. Our cardiology practice isn't open on Saturdays and or at night, so that it's limited. They're limited. So how soon should you? What can you expect to be determined? You go by the patient, are they working, or they have transportation, etc. This is at the bottom line here. For adults with confirmed hypertension without additional markers of increased risk, a blood pressure target of less than 130/80 may be reasonable. May be reasonable. That's solid evidence-based recommendation, isn't it? Well, it isn't. I mean, this is a hope. But when you're counseling patients as to whether you want to start drug treatment for this low-risk group or wait and watch, because after a year their office pressure may be lower, or they may have white coat hypertension. So this is something that concerns me, that it won't be enough thought in counseling, which is difficult because you have time constraints. Okay, but let's go then to the next step, out of office pressures. The current classification is sustained hypertension is high in the office, high at home. White coat hypertension is high in the office, normal at home. Masked hypertension is normal in the office, high at home or out of the office. And how do we determine these? Well, for some, and it's a small fraction because of cost and convenience, we put a monitor on the arm and send them out. And they go through a normal day, go to bed with the monitor on, and we do 24-hour blood pressure monitoring. And from a research point of view, this is the gold standard. This is the best evidence linking blood pressure to risk. The average over one entire day, because sometimes sleep pressures can be remarkably low compared to the daytime pressure. This is the kind of report you get with the device we're using. And you can see blood pressure varies, it goes up and down, that there's a general trend to it is lower, and the normal response to going to sleep is a lowering of blood pressure to well below 120/80 as normal. And then with awakening, up comes blood pressure back again. So this is a typical pattern, and that dip at night is normal. Those who don't lower their blood pressure at night have greater risk for future cardiovascular disease, and sometimes it turns out to have diabetic neuropathy, for example. There can be reasons for it. Okay, but this is where I think the world is turning for various reasons. This is an Omron home blood pressure device available across the way at CVS. There's a cuff, uses upper arm brachial pressure, a recording pump and recording device, battery driven, or you can plug it in. How many of you are advising this for your patients? Looks like more than half. Okay. How many of you are having to bring them in and instructing?
If they remember to bring.
Well, yes, that's an issue, isn't it? Okay. How many of you are using an iPhone to help counsel the patient, or look at their pressure? Okay, I can tell you that you can simply ask for the version, ask the patient, you have an iPhone, and 120% now say yes. And second is, does the device that they buy suggest to them that they get the one that links Bluetooth link to their iPhone? That's my blood pressure, doctor, thank you. This is one measurement, but you don't want one measurement, so you can get many measurements. And this is a screenshot of mine. You're not allowed to disclose the numbers. But the point is, I mean, we have this, yes?
Does the Omron have a Bluetooth?
Yes, the Omron has it. You can ask for it. Make sure that the patient gets the one, if they want to use it, with the Bluetooth.
Okay. You know the price of it, right?
I think on Amazon it's about $80, and in your pharmacy it may vary, maybe a bit more. Yeah, but I mean, I went to Amazon, of course. But then you can get the trend. Now, what this doesn't do is transmit to Epic yet, but I hope it will soon.
Transmits to all smartphones.
As far as I know, yeah.
Is this the only home BP machine that does that?
No, there's another one. This is the most widely used now. There's a very good one, a European product by Withings that I have tested, and it's a little harder to use, but it transmits.
But they're reliable, like they're
You have to check them. Make sure
doesn't
that,
make a difference, like with the companies, you have to still check them.
yes.
You can
I wouldn't
calibrate
trust.
them. Yeah. You have to calibrate them all back.
You have to check them in the office, and they should be, their pressure should be within 5–10% of the office pressure. Just check it.
Like 6 points higher than what you get in the office. So it's like,
I'd say within 5%. And blood pressure varies. So now, what kind of information do you get? Well, this is an example. We studied some years ago an older version of the Omron, which was never marketed, but it's the one you can see in the box, and it stored data that you could dump down into an Excel spreadsheet or a computer. And this is a tracing from a young woman who actually used to work here at Mount Sinai many years ago, and in the office her pressure was 160/85 with the device. She goes home, and her average at home is 126/82. This is a pure white coat situation. So very helpful, and we're doing it more and more. Now, does it help with prognosis? So this is a study from Finland called a FinHome study, and the large number of reports from this group, the FinHome project, And this shows you the long-term follow-up up to over 8 years for cardiovascular events and survival. And you can see normal blood pressure is the best, that top curve. White coat hypertension, not very different. A little bit different, but not significantly different. Masked hypertension, high out of the office, normal in the office. Almost as bad as sustained hypertension, which is the bottom line. Now this is the best data that I know of for long-term assessment of home blood pressure measurement. And other studies are available from this group to support the view that this is the way to go. And get patients out of the office, you have more time for other things. They're participating. For those of you that are interested in this strategy and home self-care, including medication titration, there are a series of papers from England authored by Roger McManus and his colleagues. I don't have data to show you, but just to say that they're using home blood pressures and telemedicine to treat hypertension. And it looks like it works. And you can anticipate, what does this do to cost? What does this do to phone calls to the office versus emails? How much training is involved for the patients? There's a lot to be done. But I think this is where we should go. Now, pharmacy managed hypertension is going on in Canada. It's progressing fairly rapidly. So that's another alternative. Worksite programs, which we hope would be a valuable solution in the past, seem not to be as effective, but are coming back. So I think that's the point. Out of office pressures, home, maybe worksite, maybe kiosks. What's the company LabCorp? You send a patient to LabCorp for a blood test, why can't they have their blood pressure taken and sent to you, for example? So the blood pressure management has got to move out of our offices. It's got to spread to a much larger population. Okay, lifestyle improvement. What does that include? Now, yes?
Can I just a quick note for the blood pressure monitoring at home? I'm a huge proponent, like I think most of my colleagues. What I've asked the patients is avoid the wrist cuff, and I want to ask your opinion on that. Is that good or bad? And number two, for the measurements, they tend to take them in the morning, and I say no. If you're always either for the meds, take them in the afternoon or the evening. Is what I'm telling them appropriate?
Well, yeah, yes. The wrist cuffs have not been studied. All the data that I refer to is with the brachial arm cuff. So I don't trust the wrist cuff, but there are reports that for very overweight people, the wrist cuff may be the better choice because you can't find a cuff big enough. The second question.
The timing of them.
Yes, timing.
Like,
this has been studied actually, and the current protocols, the FinHome protocol, requires 2 readings, number 1 and 2 in the morning, and 3 and 4 in the afternoon, pre-dinner. It looks like from analysis of a lot of their data, the morning pressures are the most important. Blood pressures tend to rise after awakening, sometimes to above previous daytime levels, but that looks like that's the best predictor. And there are a couple of reports for that. Okay, lifestyle. The bottom 4 of these are ones that are on the traditional list. But I just thought about what affects, what part of lifestyle has to do with medicine taking. I don't know how you classify it, but I decided to put it in as a lifestyle improvement to include adherence. And maybe the most important of all. So I think it has a place here. But it's smoking cessation, of course, weight reduction for the overweight, of course, increased exercise, of course. And how do you do this? In the Mount Sinai, how many of you have walked the Mount Sinai Mile? Just walked. I did it once. It's boring and it's unpleasant. and it's not well, the art is bad. So that's for Mount Sinai employees. You've seen the sign and walking. And here's something that we encourage people to do, and I don't know that it's in use at all. But that's the point, is that there are many proposals to improve outcomes through lifestyle. and reducing high salt intake. These are the standard items. And you could add others having to do with tranquility, treating stress, et cetera, et cetera. So, yes.
5 minutes left. We have about 5 minutes.
Okay, I can, they're coming up. Okay, this is just a reiteration of what I said. For lifestyle benefit, what works in the long run? And you can't find much, except for this one study by Cook that shows that in a small study comparing salt restriction and free salt intake many years ago, conducted by Dr. Welton, they found that long-term effectiveness was found. Small study, single, it's not a lot, but I think it's helpful. Okay. I include this under lifestyle. This recent Barbershop report that I mentioned earlier. This was a cluster trial conducted in Los Angeles in barbershops in neighborhoods. They recruited barbershops. Now, it has some flaws. It's a relatively small study, but nonetheless, Dr. Victor in Los Angeles was able to pull this off. And any of you from NYU? Dr. Rationale, okay, he's a pioneer in this area, and I'd love to have him come up here and talk about his experience.
He's come before.
He's been here?
Yes.
Great, I didn't know, I'm sorry, I missed him. But we know each other from committee meetings. Anyhow, this is sort of what they did. They compared barbershops. So this, not within barbershops, like a clinical trial where you have a placebo or active drug, but in the same site, but different barbershops. Average age 54, a little overweight, systolic pressure at baseline, you can see the bottom there, 155-ish. And at 6 months of the comparison of the two groups, much lower blood pressure for the intervention barbershops on average compared with the non-intervention control bar. What was the intervention? All the barbershops gave advice. So the barbers asked them, do you have high blood pressure, take care of, or a doctor, etc. But the intervention group included a pharmacist embedded. The pharmacist embedded assessed the patients and made adjustments for treatment and discussed, and you talk to your doctor, etc. So it was an active and costly, they had put a pharmacist in the barbershop, costly intervention. Nonetheless, as you can see, the change in blood pressure is very impressive, almost like sprint. And these are the data published. So if you go from left to right, in the intervention group, you can see the pressures are much lower on average of all barbershops. And in the control group, very little change. A little change, but not enough change, not enough to satisfy. So this is where I'd like to stop, because what I think the implications are that we are dealing with a population problem, and strategies for improving the population's health over long periods of time are very new to medicine, except for vaccination. We don't, it just is insufficient study of or awareness of how to do this, how to change the behavior of large numbers of populations to lower blood pressure to prevent cardiovascular disease. So I think this is a very exciting new area of, you might say, sociology medicine emerged. And I look forward to many other studies like this to help us solve the problem. Yes?
But isn't there a movement now to also like sort of mandate lowering sodium in all kinds of foods?
Yes, the city of New York has been a bit of a pioneer and they've fallen back. But and in England, it's now quite advanced to reduce salt intake.
Have they looked at before and after? I mean, it's like, you sort of mandate smoking cessation and like American business like that. Have people actually look sort of, the argument is that it may not actually help.
Well, the answer is it's very